My name is Manpreet. I'm the ST8 intensive care trainer. I will be presenting a presentation on neuroprognostication after cardiac arrest. And this is based on the guidelines, mainly from European Resuscitation Guidelines, American Heart Association, and Neurocritical Care Society. So our learning objectives will be to understand the hypoxic ischemic brain injury after the cardiac arrest, review the guidelines recommending the timing for neuroprognostication, and recognizing what are the reliable predictors of poor neurological outcome, understand the multimodal prognostication strategies. So why neuroprognostication matters? Many post-cardiac arrest patients would remain comatose for a very long period of time. So their neurological recovery will be determined on these parameters, and then that can help us out to identify the survival rate and the quality of the life. Neuroprognostication also guides us making an ICU decision making, and also help in counseling the families that what would be their future outcomes and what is the prognosis. And it also avoids premature withdrawal of the life-sustaining therapy, because some patients actually can wake up after 24 hours, after 48 hours of even a catastrophic brain injury. So coming on to the pathophysiology of hypoxic ischemic brain injury. So when there's a cardiac arrest, then it leads to hypoxemia. It will lead to global cerebral ischemia, and therefore the ATP is depleted. It will lead to excitatory neurotransmitters influx, mainly the calcium and the glutamate, and that will create an oxidative stress environment. It will lead to cerebral edema and eventually causing the neuronal cell death. So this presentation is mainly based on the guidelines from the European Resuscitation Society, as well as 2023 Neurocritical Care Society guidelines, and also on the recommendation from ILCO. So timing of prognostication. So prognostication should ideally be delayed, should only be done at least at 72 hours or more after the return of spontaneous circulation. And if the patient needs rewarming, especially if you have used targeted temperature monitoring, then again, we have to wait for at least 72 hours before commenting on any prognostication of the patients. And we have to make sure that we rule out any confounding factors, which I will discuss in the subsequent slides. The major confounding factors could be if the patient is on sedatives, on neuromuscular blockers, so they should adequately be warned before making a decision whether this patient is not responding to any treatment. And hypothermia, as mentioned, that it needs to be treated first, neuroprognostication. And if there's a recent rewarming, then we have to wait for at least 72 hours. Then metabolic abnormalities should be treated. Hypoglycemia, hyponatremia should be treated first. And also, if the patient is hemodynamically unstable, then again, those need to be treated. And then only we should comment on further. So clinical examination wise, we have to do pupillary light reflex. Again, I will show you the flow chart, why I'm talking about this, which needs to be done using a dedicated pupillometer, which is available in our ICU. And then we will also check the corneal reflexes. We also need to see the response to the pain, motor response to the pain, and whether the patient is having status myoclonus. The reliable clinical predictors are if there are bilateral absence of the pupillary light reflex at least 72 hours or more, or if the patient is having status myoclonus within first 48 hours, if the patient has got poor motor response, that is M3 or less, which again on its own is not reliable, but it's a strong predictor that the outcome would be poor. And overall, we have to make sure that we use clinical examination. On the top, we have to have a multimodal approach before we comment on neuroprognostication of any patient with hypoxic brain injury. So normally, if you see this burst suppression on the EEG, again, not a good prognosis. And we also do somatosensory evoked potentials, which basically assess the cortical sensory pathway. And if there are bilateral absence of N20 response, again, it's a strong predictor of a poor neurological outcome. And the good thing is it's not, or it's very least affected by the sedation. So again, a very reliable indicator. Then we also check some serum biomarkers. The common one is the neuron-specific analytes. There are other serum biomarkers as well, which is S100B, a neurofilament light chain, and we have to interpret basically all these biomarkers with other modalities before commenting on the neuroprognostication. In terms of the neuroemerging, the commonest procedure we do is CT scan, which can be done immediately as soon as the patient is presenting features of hypoxic brain injury. So if there's a loss of gray white differentiation and if there's a cerebral edema present, again, it is a strong predictor that the patient has got a poor neurological outcome. MRI, especially the diffusion restriction in the cortex and basal ganglia, again, is a marker of a poor neurological outcome. And as we say, CT scan is the early investigation, but eventually MRI is more sensitive for hypoxic injuries. Sometimes the patient can have an initial CT scan normal, reported as normal, but eventually on day 2, day 3, when we do an MRI, it will suggest that the patient has got hypoxic brain injury. And therefore, again, it's used as a multimodal assessment rather than on its own. So this is the flowchart I was talking about. So this is as per 2021 guidelines. So this is talking about the neuroprognostication of the comatose adult patient after resuscitation for cardiac arrest. So if the patient received targeted temperature monitoring, especially for hypothermia, then we have to wait for at least 72 hours before commenting. If the patient is unconscious and if the motor score less than 3 or less than equal to 3 without confounding factors. The confounding factors can be either the patient is on sedation, on analgesia, neuromuscular blockers, hypothermia, severe hypotension, hypoglycemia, sepsis, any metabolic abnormalities, and respiratory derangements. So we have to make sure we have ruled all these out, then only we can move ahead. If the patient is unconscious and the motor score is less than 3 at 72 hours or more with no confounding factors, then we move ahead. Then out of these two, if these are positive, then it is a poor neurological outcome. So what are those? So if the patient has got 2 of these, either absent pupillary reflexes and corneal reflexes at 72 hours or more, if bilaterally absent N20 SSEP waveforms, or if there is a highly malignant EEG, which basically means there's a suppressed background with the periodic discharges or a burst suppression in itself at 24 hours, again, it carries poor prognosis. And if the status myoclonus, early status myoclonus within 72 hours, and neuron-specific analysis is a biomarker of the brain injury, which should be more than at least 16 mics per liter at 40 hours or at 72 hours. And if on the CT scan or MRI, if there is a diffuse and extensive anoxic injury. So out of these 2 positive, then the chances are the outcome is poor. If not, then we have to again observe and reevaluate. So coming on to the NSE levels, normally it's done between 24 to 48 hours, but it can be done at 48 hours, 72 hours. Further, that will support us the trends that it is a poor, likely poor outcome. But again, it should not be evaluated on its own. It should be in collaboration with the other clinical findings and other testings. Sustained myoclonus basically means a myoclonus happening for at least 30 minutes or more. So, avoiding the self-fulfilling prophecy. So early withdrawal of care may bias the outcome. So therefore, as we mentioned, ideally we should wait for at least 72 hours before commenting anything. And these guidelines helps us emphasizing that delayed decision-making is needed, especially to understand what's happening to the patient, and helps in discussing about the survival and the outcome with the family. And as we say, we should not only use one parameters, at least 2 independent parameters should be done before withdrawing the life-sustaining treatment. So the key take-home messages would be delay the prognostication for at least 72 hours, exclude all the confounders that we have discussed, always use a multimodal strategy, don't believe on one particular strategy, and then combine the clinical examination, that is the pupil reflexes, corneal reflexes with EEG showing burst suppression, SSEP bilaterally absent, biomarkers as we discussed, NSE levels more than 60, mics at least at 72 hours, and imaging showing hypoxic brain injury with absent or loss of gray-white differentiation. Thank you. Any questions? If not, then I would hand over to you.
Can I ask a question? So, is the advice here once you've, so if you are undergoing target temperature management, once you've really warmed, then wait 2 hours?
Yeah.
Yeah, because ideally you have to. So there are a few guidelines that says ideally you should wait for even the brainstem testing for first 24 hours after you rewarm, and then you can do the brainstem testing, because then it is not even valid if you actually do it. So yes, you have to rewarm, because it takes some time for the patient to come back to the ideal body temperature. But the rest of the things you can easily manage, like hyponatremia, hypoglycemia.
Yeah. Is it have we got to do this for every single patient that has ROS, or is it just sort of if the patient's care for the meantime? Yeah.
So not every single patient, but ideally speaking, the patient. So your question is about if the patient has got ROS or not.
Yeah, if you've got a patient that's got in with an alcohol cardiac arrest with ROS,
Yeah.
Are we taking every single one of them to ICU from neuroprognostication?
No, so I think a couple of weeks ago we did had a slide presentation from Zoe that which patients we actually admit for neuroprognostication. Yeah. So whatever has come, to the ICU, then we have to do that. But yeah, sometimes you have to, just decide in the ED if it's unsurvivable injury.
My name's Eilish. I'm one of the CT3s in ICU at LRI, and Zoe had this journal to do a critical appraisal with everyone. So this is the top trial that was published in November 2025, which looked at liberal or restrictive post-op transfusion in patients at high cardiac risk. So why do we care? Why are we interested? Well, basically, with any transfusion, we're weighing up oxygen delivery to the patient's tissues versus the transfusion-related risks. So it's a bit of a physiological trade-off. And we also talk about sort of change in hematocrit and the effect on flow through the vessels as well. We usually use quite a restrictive target in ICU, which typically works fine. But there's not been that much information on what impact that could have on patients with a high cardiac risk where they've already got some ischemia and potentially need a slightly better oxygen delivery. So here's a selection of stickers to represent the study design. It was a big multi-centre study across 16 veteran affairs medical centres in the US. So that we'll talk about the generalizability of that data. It was single blinded, so ultimately the participants didn't know which group that they were going into. It wasn't possible for the clinicians to be blinded, obviously. It was a parallel trial, so the intervention and control were occurring simultaneously, and that's usually a better thing than occurring one after the other. And then it was also a superiority trial. So ultimately, we were trying to find out if the intervention was better than the control, as opposed to just equivalent or non-inferior. So whenever we're doing a critical appraisal, we would set out with our PICO. So that's our population, intervention, control, and outcome. The population was 1,428 veterans who were mostly male and were at a high cardiac risk. So they defined that as patients with known ischemic heart disease, a previous MI, if they'd had heart failure, previous stroke or TIAs. And in that group, there were patients who were undergoing major general or vascular surgery. Our intervention was this liberal group, so their target was an HB of greater than 10 grams per decilitre, and the control was that more restrictive group that we'd be more familiar with of 7 grams per decilitre. And then the primary outcomes was looking at things like AKI, strokes, and MI in a period afterwards. So what is it? So this is quite a busy slide of all the characteristics that they took into account when they were randomising. And ultimately, you can see that they were quite well matched. If you sort of scan from one column to another, if there were, 317 patients with a past history of smoking, there were 320 in the other group, and that's quite consistent throughout. But the standout things are that you've got in both groups, you've got kind of like 96 to 99% male in both groups, and then the average age is like 69.7 and 70.2. So obviously it's older, mostly male, and then all having sort of the expected characteristics that you see in a high cardiac risk population. So a bit more detail about the intervention and control. So in the intervention group, they'd be transfused in some way if their hemoglobin was less than 10 grams per deciliter, and basically they'd get a unit if it was above 8.5, 2 units if it was between 7.5 and 8.5, and 3 units if it was less than 7.5. So it's really quite significant amounts. Whereas in the restrictive group, they wouldn't get a transfusion at all until it was less than 7, and they'd only get 2 units if it was less than 5.5, so that's pretty low. And ultimately, what ended up happening is that you'd have, in that liberal group, you'd have about a third of people getting a unit, and 2/3 had 2 or more units. Whereas in the restrictive group, 3/4 of them didn't have any transfusion at all. It's important to note that they had some major protocol violations, which is expected, like protocols aren't always followed, and they used an intention to treat analysis, which basically means they don't exclude people just because they didn't follow the protocol perfectly, which is usually a better way of doing trials. And you can see there's kind of an expected transfusion reaction. So obviously if there was a transfusion reaction or a major hemorrhage, then they would stop the infusion or not follow the protocol. If that makes sense. Some more stickers to represent all the outcomes they looked at. So the primary outcome was the things that happened within the first 90 days. That'd be death, AKI, ischemic event in terms of the heart or a stroke. And then the secondary outcomes were looking at infection, duration of hospital stay, death within 1 year, and then things like worsening heart failure, any cardiac arrest that didn't result in death. So if there's anything important to mention about those. Okay. So I'll show you the sort of most important graph from the paper with all the results, and then I'll just kind of run through what that's actually showing. So you've got the primary outcomes at the top, the secondary outcomes throughout. And if you kind of just look at the diagram on the right, you can see there's generally sort of a shunting of the squares towards the liberal side, which makes you think generally this liberal is better. But the dotted line is that line of no difference. So if the confidence intervals cross the line of no difference, then it means there's no statistical significance. And all the lines pretty much cross the line of no difference, so we didn't actually get the statistical significance. I've outlined some of the interesting ones. So actually, we often worry with transfusion about worsening heart failure through overload, and interestingly, this actually favoured the liberal group, and they wondered if it was to do with just better oxygen delivery to them. And then one sort of further down the bottom, so although it very, very slightly crosses the line of no difference, it just goes into that sort of 1.01. So potentially the 90-day cardiac complications with MI, maybe that helps having that liberal approach. So we always look at sort of like the strengths and weaknesses of a study in critical appraisal. So it was quite a rigorous design. Blinded endpoint adjudication means that for any of the sort of subjective things that they were measuring, they'd always have a independent committee to check that had definitely happened. So, for example, some of the secondary outcomes would be like worsening heart failure, and you'd need a committee to say yes or no, had their heart failure actually worsened. That's always a good thing. I explained intention to treat analysis before. That's basically just not excluding patients just because they didn't perfectly follow the protocol. And then the protocol adherence, i.e. the correct administration of blood products when they were required, was pretty good. It was like 92 to 96%, and their follow-up was about 96% as well. It's quite good in terms of clinical relevance. This is a true population that we see. They mentioned in their discussion about robust hemoglobin separation. So they did actually there was clearly a difference in the type of hemoglobin that they were aiming for, rather than just saying that the intervention was greater than 9 versus the restrictive being greater than 8 or something, which wouldn't make too much difference. And it addresses a genuine clinical uncertainty that people sort of ongoing questions about it. The poor things about it is that it is an open label design, which ultimately means there was no placebo for a blood transfusion, believe it or not. It wasn't very well powered because the outcome or the event rate was pretty low. So they thought it would be like 30%, and it was actually only 10%. So when you've got an event rate that low, you need a much higher number of people involved. So they estimated they need about 36,000 patients to be able to get a statistical significance from any of this. And then the obvious one is the limited generalizability. So they're all war veterans and male, and they're all kind of in their late 60s. So can we use this apply this in our usual population? What about women, young people, non-veterans? So this is where we sort of prompt a bit of discussion of what you think about it. Does anyone have anything interesting to say, or any thoughts about how they would use that in their future management of anemia post-operatively patients?
Question. Did they mention anything about the inclusion criteria, whether the patients, surprisingly, the heart failure complication is actually less the liberal size, whether there was a difference in the pre-comorbid status in the liberal group versus restrictive? Did they mention anything about it?
So if I go back to this big graph, it does have, so this is their kind of perioperative cardiac risk at the bottom. So that's their classes of there, and it was pretty well matched. And the same, you can sort of just scan from side to side and say, yeah, that's 31% versus 34 on the diuretics. Yeah, they match them pretty well.
I'm interested that the results, if anything, favour the liberal side, because I've become much less judicious in blood transfusion over the last few years because of concerns about, sort of depleting 2,3-DPG with transfusions, citrate administration, temperature, things like that. And so you're almost, I'm interested, there haven't been more worrying events with giving so much blood.
Yeah,
well, they probably don't really need it.
Yeah, they calculated that the liberal group received 6 times more blood as well. Yeah. So even if there was a little bit of a benefit, you could probably do some kind of like cost effectiveness analysis. Is there something else better we could spend our money on giving lots of people?
Was there a discussion about why A, they picked veterans, and B, I presume it's mostly male.
Yeah.
Because mostly male, because most veterans are male, I presume. But so what was it was funded by?
It was just funded by the Veterans Affairs.
Oh, I see.
Yeah, whatever that logo was that I had at the beginning. The Department of Veterans Affairs.
Oh, I think that was veterinary. Oh, that makes more sense.
That one, yeah.
Why it was a
Yeah. So the conclusion that they came to, that they think that the restrictive approach is safe, but there's potentially a very, very small group of patients that maybe have severe heart failure, or very severe ischemic disease that would benefit from a liberal approach. So it's basically just use patient-centered care and MDT, etc.
It's a lot of confounding factors. You've got patients on major surgery who's got a class 4 heart failure and their mortality and other risks. So it'd be quite difficult to extrapolate that just for blood transfusion as a reason why they've either deteriorated or got better.
Again, that's what they meant by the power, I guess, because they've had loads of patients.
Why did they choose 7 or 7.5? Either 10 versus 8 would be a good comparison, because in that case, you would still, so let's say if the patient is 7 or less and they haven't actually given blood, but most of the studies does show that if you choose 8 versus 10, then the outcome would be more or less the same.
Yeah.
So that's
But
what.
I think that came up as one of the strengths actually, that it was robust hemoglobin situations. You didn't just have them to be different to even be able to see the difference. But there was a YouTube video from Med Journal Club that does a really quick run through it. If you need to see it again.
You're perfect. We're all sorted.
All intensive care patients are slightly different, and the trials don't work to come up with an answer.
Especially the cardiac patients could have something else on the top, so you have to think of
They also didn't. One of the things that came up was that they didn't look at like diuretic use either. So if they're doing lots of blood to someone, but then you're giving loads of diuretics, and then the outcomes were AKIs and things like that. I thought that was interesting.
Thank you very much, guys.
Thank you.
Yeah, that's good. Very interesting.